Okay, so in proceeding with the musculoskeletal assessment, we're going to go ahead and assess the neck. So I'm looking at posture. I'm looking for any swelling. I'm looking at the alignment of the neck. It is straight. I don't see any swelling. I don't feel any swelling. Just in feeling. So I can have him turn around, look at the back of the neck for the same thing. Posture, alignment, any swelling, no swelling is seen. Alignment is good. So I'm going to palpate at the base of the skull, down the neck, feeling for any abnormalities, any bones that might be out of place, anything like that. Also feeling for tenderness. Was that tender? No. Okay. So I can also have him do some range of motion exercises with the neck. So I'm going to have him tilt his head forward, do some forward flexion, and back. So that's some extension. I'm also going to have him tilt his head from left to right. Okay. And then turn your head the same way. That's some rotation. Okay. So the patient has good, range of motion in the neck. So I'm also have him do a shoulder shrug, so shrug up against me. Okay, so no problem with that. That was equal, even on both sides. I can also check for a trapped nerve, so I'm going to have him kind of turn to the side for me. Well, okay. Actually, I'm just going to sit. So tilt your head that way for me. Does that hurt?
No.
No? This way?
No.
Any pain? So if he had pain with that, that could indicate a trapped nerve, which he doesn't seem to have. In looking at the spine, so I'm going to assess that now. I'm going to look at the spine. I'm going to look at the alignment of the spine, look for any swelling, any scars, previous surgeries, anything like that. Abnormal hair growth, lordosis, kyphosis. Patient has a normal spine from what I can see. So from there, going to go ahead and palpate the spine. So I'm palpating down. So I'm palpating from the cervical region all the way thoracic, lumbar, sacral, and so on. So, and iliac, of course. So I didn't feel any abnormalities there. I can also feel the muscles on each side of the spine. And I'm just feeling for any abnormalities there with the muscles on each side of the spine, and I don't feel any abnormalities with that. Any pain when I was palpating that? No. Okay, so I can also do some range of motion exercises with the patient. So I'm going to have him go ahead and laterally flex. So he's going to go from side to side for me. Kind of, yeah, there you go. Good. And I'm also going to have him arch his back for us. Okay. And then I'm going to have him bend down and touch his toes or knees, whichever is most applicable. So while he's doing this, I'm going to go ahead and feel for any scoliosis up the spine. And I don't feel any. Also, I'm going to have you stand back up and do this one more time for me. So I'm going to put my 2 fingers right here on his spine, and they should separate and increase in space when he bends over. So I'm going to go ahead and have you do that one more time for me. And they do. They expand for me. So that's a normal finding. I can also have him cross his arms and then kind of turn from side to side with just your spine for me. Okay, so that's normal. Then we can go ahead and have him, we're going to go ahead and assess the shoulder. So I'm going to look for asymmetry, any scars, any surgeries, anything like that, and I see that it is very normal, no surgeries, no scars, anything like that. I'm going to palpate from his clavicle to his shoulder, so I'm palpating to the acromion of the shoulder, and I don't feel any abnormalities with that. So we can do some range of motion exercises with the shoulder as well, so I'm going to have him turn around for me. Okay, with your arms, we're going to go up towards the sky. Okay, back down. Now out sideways. Good. And then you're going to do like this for me. Okay. And then you're going to turn back around for me. And you're going to try to touch your shoulder blades for me with from the back. There you go. Okay. And the other side. Okay. And so in order to check for rotator cuff injuries, which we can also do with the shoulder, we're going to do all these same exercises again, but we're going to put resistance on the patient as they perform these. So let's start back here. Go ahead and do that same thing with me. and he is able to resist, even though he is unsteady on his feet. He resists my pressure. Same thing. So forward, and he resists that. Out, resisting that, and then put your arms out like that again, and then he's able to resist with that as well. So no issues with that. We can also check the elbow and the wrist. So what we're going to have him do is bend his arms up. Touch. Okay, we're going to put this more on you. Okay, so do that one more time for us so we can see. Okay, so normal elbow there. And then we can also have you bend your arm straight out for me. Kind of bend your wrist up. Okay, so normal wrist and elbow thing. I can also palpate for any tenderness, any warmth, any edema in both the wrist and the elbows. I can also do some passive range of motion with him, checking the movement of his wrist. I can go ahead and assess the patient for carpal tunnel. And so I'm going to assess the strength of his fingers and thumbs. This is with any normal test. So go ahead and lift your finger up for me. Okay, so he has good strength in all of his fingers. I can do the Durkin test to assess for the carpal tunnel. I'm going to press on this little nerve right here. Do you have any numbness or tingling in your arm? No? And then I can do the Tinel's test, so any electric shocks feelings while I'm doing this? No. Okay. And I can also do the Phelan test. Keep his elbow straight for me. He's going to bend his wrist up for me. And I'm going to press right there again on that nerve. Any tenderness or tingling? No. Okay. So he does not have carpal tunnel. I can also, in assessing the hands, I can have him make a fist for me and stretch him back out. Okay. I palpated for some tenderness. No tenderness. I'm looking for any deformities, which I do not see any. I can assess capillary refill again, just for vascular perfusion. And capillary refill is good. So we can go ahead and check the hip and knee at this time. So I'm going to have the patient go ahead and lay down for us. Okay. So what I'm going to go ahead and do at this point is I'm going to assess the sciatic nerve. So I just need you to take it. Okay. So I'm going to pull his leg up. Any pain with that? No. Any pain with that? Okay. And go ahead and do it for yourself for me. Pain with that in your back? Okay. And then I can also pull his foot back. So bending I'm dorsiflexing his foot right now. Any pain? No. Okay. So normal sciatic nerve findings. I couldn't do that with the spine, so I figured I'd go back and hit that. So now I'm going to go ahead and assess the hip. So in assessing the hip, I can feel of the hip, make sure that I don't feel any abnormalities, no swelling, no tenderness, any swelling or any tenderness with that. No. Okay, so that's great. So I'm going to go ahead and have you flex your knee. You're going to bend at a 90-degree angle for me. Oh, lovely. There you go. Okay, and then do that with the other leg. Any pain? No? And then I'm going to go ahead and adduct the leg. So I'm just log rolling the leg to check range of motion as well. He could do this himself, so roll. Okay. So that was passive and active. I'll go ahead and do some passive range of motion here. Make sure that I can do the same things he did without any pain. Any pain? No. So no pain with that. So I'm going to go ahead and start with the knee now. So while he's laying here, I'm going to go ahead and demonstrate how you do the bulge test. So with the bulge test, you would check for effusion of the knee. And with checking the effusion, I'm going to take the fluid. If there is fluid on the knee, I would kind of push my hands out this way. You can't really see. But like this. And if there was fluid in the knee, it would move as I was pressing it around in the knee. So with the knee, I'm going to go ahead and feel for the joint temperature of the knee, palpating the knee for any bony processes, anything like that. And I don't feel any abnormalities with that. It's not hot, indicating inflammation. I can also check flexion and extension, which we just kind of did with active. He did that himself. We kind of checked active and passive range of motion with the knee when we were bending our hip and stuff to check as well. So I can also assess his gait, which I'll do later in assessing gait. And that would indicate if he had an abnormal gait, it could indicate some knee issues, not always. So with the ankles, there we go. So with the ankles, I'm also going to palpate for tenderness, swelling, edema, anything like that. And I don't feel any of those things, so that's a normal finding. I can also do some range of motion exercises and have him do. I'm going to have you invert your foot, so turn your ankles inwards. Well, your ankle, just your ankle. Oh, there you go. Okay, so he's able to do that, and then he's going to invert them, so he's going to point them outwards for me. Good job. And he's going to dorsiflex, so he's going to pull his foot back, and we're going to point your toes. And that's plantar flexion. So all of those are normal with him. I can also do that myself. I can check that range of motion. And he has good range of motion in the ankles, no issues there. From there, I can go ahead and check the foot. If I was checking completely, I would look at his shoes for uneven wear. I can also inspect and feel the feet. I'm going to take the socks off. Tickle Sean's feet, so I'm trying not to tickle him. So I can look at the foot, see if there's any redness. I can feel it, make sure it's not cold, because if it's cold, it might indicate some circulation issues. Checking for tenderness as well, deformities, looking for any scars. I can feel his pulses, so I can feel the posterior tibial right there on the inside of the ankle. And I can also feel the dorsalis pedis right there on the top of the foot. And he has good pulses in both of those feet. And I can also do the same exact thing, so we're going to point our toes. We're going to pull our foot back. So dorsiflexion and plantar flexion are good. He's able to do that. I can do it myself once again. And checking the foot. No abnormalities with that. So I can also go ahead and check the gait. So he's going to go ahead and stand up for us. We're going to do a little bit of walking. I'm not sure I want to get this in the camera. Let's do walk over there. We're going to try that. Okay. So, with checking the gait, I'm looking, first of all, just walk a little bit for me. Okay, stop there. Okay, so in looking at his gait, I was looking for any pronation or supination. If he was walking pronated, his foot would turn inwards when he walked. If he was walking, with supination, his foot would turn out when he walked, and it did not. His gait was normal. I didn't notice any abnormalities. He's not limping, nothing like that. I can also check him walking heel to toe, which is tandem gait. Okay, so he's going to walk heel to toe for us. Start back there. Walking heel to toe. And he's relatively good at that. And so he's able to do that. Tandem gait is good. He's going to walk on his tiptoes. And on his heels. So he's doing good with that. No issues with that. I can have him close his eyes and balance on one foot for me. And he's able to do that other side for me. So that was checking the Romberg test, which is good. I can also have him hop on one foot, but we won't because we don't want to fall today. But we can also do that. I can also check for pes planus, which is flat foot. He is flat-footed. And then pes cavus, high arch. He does not have a high arch, and any bunions. He does not have bunions. With his toes, I could check capillary refill and temperature, which we already checked temperature, but I can check capillary refill while we're just standing here. Okay, capillary refill is good. So from there, we're going to go ahead and move on to the nervous system assessment. We're going to adjust the camera really quick while we're waiting. Okay. Get our tools ready. Taking a small break. Still waiting. We had to take a bathroom break. Okay, and we are back for the rest of our nervous system assessment. So to begin, can you tell me your name?
Nicholas.
And your date of birth?
7/1/95.
Okay. And you know the date?
October 15th.
He's close enough. It's the 14th today. But you work night shift. You don't really know what day it is anyways.
Yeah.
What is the year?
2017.
Who's president?
Donald Trump.
Where are we?
We're in Lawrenceburg, Kentucky.
Okay. What are we doing today?
We are recording your nursing videos.
Okay. And how are you feeling?
I feel fine.
Okay. So I was just asking him some orientation questions, just to assess his neurological system. I can also ask him if he's had any dizziness. No. Okay. So with dizziness, you could have some different types of dizziness. You can have vertigo, which is where you're kind of nauseated, and you feel dizzy. Presyncopal lightheadedness, you would pass out, black out when you stood up. And if you had some disequilibrium issues, then you would be unsteady on your feet. You have issues. You probably touch things when you walk because you feel so unsteady. But we don't have those problems. Just want to cover dizziness really quick. So we can go ahead and start assessing some of the cranial nerves. So there are 12 cranial nerves, and we can assess them all. So our first cranial nerve is our olfactory. So this is the sense of smell. So we're going to sniff a sock. Is it clean?
Yes.
Alright. So olfactory cranial nerve is intact. Optic would be the second cranial nerve, and it relates to vision. So he can see me. Obviously, he was able to do well on the vision test we performed earlier. So optic nerve is intact. Number 3 is your oculomotor, which is responsible for your pupillary reflex and your eye muscle movement. Had good pupil response earlier. We can go ahead and check that once again, just to check that third cranial nerve. Okay, pupils are constricting, so a normal finding that nerve is intact. Our fourth cranial nerve is the trochlear nerve, and it is intact because we are able to move our eye muscles. The fifth cranial nerve is the trigeminal nerve, and he is able to clench his jaw for me, able to open his mouth. So he's able to move the mandible, so that nerve is intact. The abducens is the sixth cranial nerve, muscle movement of the eye, once again, intact. Seventh is the facial nerve. It's responsible for taste. And can you smile at me? Yes. And can you frown at me? Yeah. Okay. So that's responsible. The facial nerve is responsible for all those things, and it is obviously intact because he's able to do all those things for us. The eighth nerve is the vestibulocochlear, which is responsible for hearing. He's able to follow my directions, therefore he's able to hear me. And there was a normal Rennes-Weber's and whisper test, so I would say that nerve is intact. The ninth one is the glossopharyngeal, which is responsible for gag and swallowing. We tested the thyroid earlier. He was able to swallow, so that is intact as well. The 10th cranial nerve is the vagus nerve, also responsible for swallowing and some of the muscles in the throat. Once again, still intact. The 11th cranial nerve is the accessory nerve. That's responsible for movement of the larynx and also of the soft palate. Those are all intact. He's able to swallow. And our 12th and last cranial nerve is the hypoglossal, or the nerve responsible for swallowing and tongue movement. So he's able to move his tongue for us. Yep, so he does well with that. So that is also intact. I can also look at the bulk of the patient. I'm looking at even muscle distribution. He has equal muscle distribution. He's not, deficient on one side. Strength, if I'm pulling him, he's going to push up against me. I'm going to pull. He's able to resist me, and so he has good strength. He has good muscle tone. He's able to let his arms hang freely. Yeah, okay. So good muscle tone there. He doesn't have any abnormal movements like tremors or fasciculations, anything like that. He's able to sit up straight for us. So he has a good station. He's able to maintain erect posture. And then we once again tested his gait just a few minutes ago to see if there's any imbalances like in his cerebellar function, and there was not. We can go ahead and test rapid alternating movement. So I'm going to have you turn your hands over like this. And he's able to do that very well, and then take your fingers and touch. So he's able to do that well, so he tests good with that. We can also do the finger to nose test, and so I'm going to have him touch his nose and touch my finger. Continue. Okay, other hand. And he's able to do that very well. And we can also test heel to shin while we're at it. So I'm going to have him lay back for us one time. You're going to put your heel on your shin and move it down and back up the leg. Okay, other side. Okay, so that is intact as well. So then we can also just assess light touch on the patient. Can you feel that? And I can also do a pin prick, and we'll just use this for a pin prick. And you can feel that everywhere I'm touching. Okay, so he has normal sensation in his limbs for us. So we can also test that on the face as well. You feel those places I'm touching? Feel those pricks? Yeah, okay. So we can go ahead and have him sit up for us. And problem. Okay, well, we could assess the his ability to detect position. So we'll go ahead and do that. Even though you can't see it, we'll go ahead and do it. So he's going to close his eyes and tell me which direction I'm moving his big toe. And he is correct in that. So his position is not altered. We can go ahead and test some vibration. So I'm going to take my tuning fork and put it on some bony prominences and see if he can feel vibration in those joints. You cool on both sides?
Yeah.
Is that a funny feeling?
Yeah, it just feels weird.
Okay.
Especially my knees.
So he's able to feel the vibration on bony prominences, which is a good sign for the neurological system. Point localization. So we can go ahead and close your eyes. Where did I touch you?
My left tricep.
Okay. And we can do some 2-point discrimination. How many places am I touching you? Okay. So he's able to tell us that. From there, we can go ahead and test our reflexes. So to begin, we are going to assess our triceps. So what we're looking for is muscle in we're looking for movement in the muscle, the triceps muscle, and its root nerve is the radial nerve. So we're just going to go ahead Do the other side. And we're looking for muscle, and there was movement there. We can do the brachioradialis, and the root nerve is also the radial nerve. So we also had movement there. The biceps, we could go ahead, and the root nerve of that is the musculocutaneous nerve. Okay. Well, I should have used my fingers over that. I'm sorry. Redo. Supposed to use your own fingers and hit them. And then we can also assess the patellar reflex. That's right. Okay, so patellar reflex, I'm going to hit right here on the knee. We have movement. And then I can assess the Achilles nerve as well, or the Achilles reflex, and the root nerve is the sciatic nerve. Figuring out how we're going to see this. Let me see. Okay, great. Okay, we're going to do the other side. A little hyper-reflexive there. Okay, so we tested our reflexes, and he has normal reflexes in all areas. I can go ahead and assess. Forgot to assess something while I was there. So we're going to go ahead and assess the Babinski reflex. So I'm going to be touching the bottom of his foot.
Oh, man.
Okay, so, and his toes actually constricted with that. Yeah. And so that is a normal finding. If his toes flared, it could indicate some neurological issues or neurological trauma, or the nervous system had some trauma. So babies have an active Babinski reflex, but in adult patients you should not see that. The toes should curl rather than flare. If we wanted to assess the patient for Bell's palsy, we could look at that, make sure there's no dripping on the side of the face. Bell's palsy as opposed to a central nervous lesion. So with Bell's palsy, it is usually top and bottom is affected. The upper and lower face is droopy. Like this would be droopy, and so would this up here. But with like a central nervous lesion or most other issues neurologically, besides Bell's palsy, it usually just affects the lower portion of the face, so the forehead is kind of spared. The patient does not have Bell's palsy or a central nervous lesion, as we can see, because there is no drooping. And then from there, we can also assess Koenig sign and Brudzinski sign. So what we're going to have him do is lay flat one more time for us. So he is laying flat. Okay, so we're going to go ahead and check for Brudzinski sign first. So he's going to uncross his legs. And so what we're going to do is we're going to have him lift his neck off the thing. And as we can see, his legs did not involuntarily come off of the couch. They stayed put. If they were to move involuntarily when his head or neck is lifted, this would be a positive Brudzinski sign. Those are signs of meningitis. And then we can also check for Koenig sign. And we're going to flex his hip at a 90-degree angle. Any pain with extension? Any pain? No. Okay, so he didn't have any pain with the extension of that, so this is not a positive Koenig sign. If there's pain, it would be positive and could indicate some meningitis. So this concludes my assessment from head to toe.